Hello and welcome to HLA Live. This is the 10th episode of HLA Live, which is our weekly programme broadcast live on the HLA YouTube channel and social media channels. Each week we talk to interesting people from the HLA community and beyond about the issues and topics that our community have expressed an interest in. The HLA has 6 pillars of leadership that we deliver our programmes on. The leader is a communicator, the leader is a manager, the leader is a negotiator, the leader is an innovator and entrepreneur, the leader is a follower, the leader is a philosopher. Many of the episodes in HLA Live will cover one or more of these pillars. This week, we are talking about the future of social care in health systems. Pedro has put together tonight's episode with the HLA Live team, Eamon, Tim, Adil, Alistair and Riddy, and brought together a fabulous panel of speakers to talk about this topic. Chairing tonight's panel will be Pedro. So, handing over to Pedro.
Hello. So, I'm Pedro, and this topic is about the future of healthcare, of social care systems. So, each year, social care spending across the nation rises due to the increased demand of it, hence why it continues to dominate the headlines. There needs to be a change in order to empower individuals to access the right services at the right time. Thankfully, we live in an age where new technologies appear almost daily, and a digital future seems ever more rich and abundant. However, when it comes to social care or events, or even healthcare, we struggle with the development and adoption of it. Even though digital care can play a critical role in the transformation to more person-centered models, when will we reach such a point? So on today's panel, we will discuss the future of social care. Joining this panel, we have Maruthappu, and he's the CEO and co-founder of Cera. Ben is currently a London-based doctor, and he's won multiple awards based on his based on his technology found through Cera, which is a home care company, and it's grown to deliver over 10,000 daily visits since its 3-year launch. Next, we have Dr. Isabel Van De Keere, who's the CEO and founder of Immersive Rehab, and it's a digital therapeutic startup that is transforming neurorehabilitation by offering personalized and engaging neurorehabilitation programs in virtual reality with the aim to improve patient recovery and reduce waiting times to access rehab. Our next panelist is Daniel Kaysen. He's a digital social care executive and a digital advisor to Care England. He also works closely with NHSX to achieve integration of health and social care via digital transformation. Finally, we have Hassan Chowdhury. He's a digital health lead at the Department for International Trade. He has also appeared on other episodes of HLA Live. So this is our panel for today, and we'll start with an easy question. So, social care system is a very complex system, from the number of varied services to the sheer number of individuals involved in its ecosystem. Is digital social care a fantasy, or could it be a reality? And if so, when? So to start off, we shall start with Ben. Ben, what do you have to say?
Great, thank you. And thanks for the opportunity to speak about this really important topic and have this encouraging discussion and hopefully debate as well. When it comes to digital social care, absolutely, I think there is scope for technology-enabled social care and using digital in parts of social care. Of course, nothing will ever replace a care worker from looking after an older or vulnerable person or someone with physical learning disabilities in their home or in another setting. However, technology and similar tools, which we've already seen in other parts of society, can be better introduced into social care to empower these members of staff so that they can spend more time caring and less time on, say, administrative efforts and work. I think digital also has a really powerful role in connecting people receiving care, care workers, and crucially family members who very frequently are involved in the care process so that they can be in touch in real time almost immediately through the power of their smartphone and respective apps or digital products. And so I think there are a number of ways in which digital can transform social care, can make it more sustainable, and can improve the quality of services that people are receiving. So I think it is a reality overall.
So much. And so, Daniel, do you want to come in? what would a different social care system look like, and is it achievable in the near future?
Definitely. Thank you very much, Pedro. Thank you for inviting me on tonight. And thanks for that start, Ben. That was great. Because I think what we're looking at now is a system which over the past 6 months has realized that digital is here to stay. Because what with the uptake, the adoption of digital technology and new tools have really taken a great upsurge in the past 6 months. And what they're doing is they're creating value where care providers and health systems and individuals didn't realize that actually there is greater value that we can get for the individual, for the system. Now, when I say about creating value, I look at it on 3 levels. I look at creating value for the person who's being cared for and supported so that they can actually achieve their outcomes, live a meaningful life. This is what technology can help people achieve. It can help them lead a meaningful life. It can also create value for the systems, for the providers of this care, because they can achieve greater efficiency, they can create greater productivity, and they can also enthuse the people who are caring by involving them in new technology and new ways of working, which allied to the old ways of working can really make digital a reality. And the third way it creates value is for the whole system. If we can actually make digital the reality that it's becoming and integrate health and social care via these systems, then it moves out of the realms of fantasy into reality, because it starts creating value for the individual, for the organizations, and for the whole system. That's where I leave it on whether digital is actually the future now.
Thank you so much. I mean, you do have some great points. And so Hassan wants to come in. Hassan, as a digital health lead, what do you have to say to everything?
First of all, thank you so much. It's a real honor to be back with HLA Live and another fantastic panel. Let me be controversial for a second. Imagine that you're flying a plane and it doesn't look like that plane's going to be able to make it. You're going to do all sorts of things to keep it in the air. And that's how I feel we're coping with social care at the moment. We've got to keep it going, and we're doing some crazy things to keep it going. But things that if it was on the ground and we had a chance to start from scratch, we would never do. And I tell you, that's the problem with social care and really healthcare, that what we're doing right now isn't what we would do if we could start from scratch. We have to continue it and make changes as we go. So in the midst of that, you've got great innovators like Ben and people who understand the way the system flows, the way that Daniel does. And their point's absolutely correct, but the foundation of it is the whole thing is a mess. And we'll go into that, I think, in more detail. But when we think about, is it a fantasy to have digital social care? It's layering fantasy upon fantasy. It's Lord of the Rings on top of Game of Thrones, right? We have somehow managed to have a division between health and care, not to do enough on prevention, not to do enough on chronic care, chronic disease. We don't have the workforce. We don't have the training. How have we kept it all going? And now we want to add digital to the mix. So any successes that we've had have been hard fought, and it's going to be important for you to know that it is very difficult for us to continue as we are.
Thank you so much, Hassan. And so you touched a bit about the transition period of going from a less digital phase to a more digital phase. And so, Isabel, taking on your experience, do you have anything to add to this? Isabel, I think your mic's on mute.
Yeah, I'm here now. I mean, from our perspective, and I think in general, what we've seen over the past few months as well, is showing the extreme value of digital tools within the health and social care setting. And I think it's all about implementation in the end, whether it is in a clinic or in a community setting or in a home setting. I think the implementation, the technology development and the digital health product development is actually the easy part. The hard part is implementing it in a good way in a clinical setting and in a home setting or in a community setting where then social care mostly takes part. and I think doing that in the right way and in a way that easily slots into, I guess, health records and the way people get access also to digital tools, where often internet and bandwidth access is often important as well. So that obviously needs to be assured to ensure that then people obviously have then digital access tools, digital health tools in their home or community setting as well. But what we've seen so far is that there is a big need for it because there's really long waiting times to, in our particular case, for example, then to access neurorehabilitation services, which initially takes place in an acute setting in a hospital for part of the neurorehabilitation patients, but a lot of it takes place in a community setting and in a home setting as well, where then I guess occupational therapists and neurorehab specialists would come into a home setting and what we've seen the past months is that all the neurorehab clinics, a lot of them have closed completely. And that meant that a lot of patients did not have access to anything. They didn't have access to any rehabilitation, essentially. Maybe the odd phone call, if they were using some kind of digital interface with the patients. But I think there's incredible potential to actually increase lives of patients using digital tools, especially within various chronic diseases in particular. So,
thank you so much. So, we're talking about digital health, social care to be reformed, or, for example, if it's going to be reformed, is it sufficient enough to support the aging population? On top of that, do we have enough financial backing for it? Or do we need to make more investments to implement it to transition it into an actual reality? So Hassan, do you want to come in on this one?
Thank you. I just want to make it absolutely clear that I can't be a bigger supporter of digital. There's no possible way for me to be more of a supporter for it, right? My entire career is about championing digital health, right? And so when I talk about how we need to have digital, I'm talking about it being the foundation of everything that we're doing, right? I'm not, and I used the phrase earlier, adding it to the mix. It's because I used to be a social worker, and I was working in the London Borough of Hackney for elder care, older people it was. And when I was doing it, I remember we had no data. We had no real way of collecting it apart from just some meaningless reports that we really just had to complete to tick a box. We weren't doing anything to support patients, their carers. We weren't supporting those who were doing the hard work on the ground, domestic care agencies, for example. So none of those things were connected. We had no communication tools. Everything was falling apart. And it was held together by people. And we don't have those people anymore. We really don't have the capacity and the workforce to be able to manage this with a people-led approach. Now, when I say that, I don't mean people are important. Of course they are. But what we need to do is make sure that they're augmented and supported by digital. And without it, we just won't be able to manage. So at the heart of all conversations is that digital social care must be a reality. It must become that reality. We have a long way to go before getting there. And I want to make it clear, what I'm really saying is that for us, the division of social care from healthcare is artificial and harmful. If you like, the over-specialization in healthcare and the fragmentation in the silos in healthcare is harmful. And the only way you can bring all that together is digital. So that's how I think we should proceed.
I mean, that's a great point, and I love the fact that you brought in the whole workforce element towards it. And so it's been acknowledged that there's still a limitation in numbers of the workforce in social care. And something we tend to joke around in our GP is that we're one day going to be taken over by robots. So talking about a future in social care, it becoming digital, is there a chance that we need less human numbers, or do we still need a lot of people? And if so, how much? And will we still have such a limitation? So, Ben, do you want to jump in on this one? Because you talk a lot about AI integration into your system.
Sure. I think the population, not just in the UK, but in many countries across the world, is growing at an accelerated rate. And COVID-19 has shown that it's particularly older populations who are most vulnerable to the virus and its consequences. Because of the ever-increasing demand, this means that there will be a larger and larger care workforce required to look after the aging population. And at the moment in the UK, there's a vacancy rate of around 120,000 people per day. As a result, I think even if we do achieve a digital social care system, which I think will be in the best interests of the workforce of people receiving care, it will be difficult to close that gap. And we'll need to look to expanding that workforce, recruiting more people, and crucially retaining them, because up to 40% a year leave their employers in care and move on to other roles. So retaining and recruiting so that we can fill that workforce gap, and that in turn can be supplemented by state-of-the-art technology, be it digital or AI, as you were mentioning.
And Isabel, do you relate to such findings in your own startup? Isabel? Okay, I think Isabel disconnected for a minute. So coming back to your point, Ben, I do agree, because based on your app, but is there a possibility of having some sort of digital like robotics or some future like iRobots coming in and helping out their people, or is this a fantasy?
I think different companies have actually already started to trial robotics in social care to look after older people. This technology, though, is very much in its early stages, and so there is a large dependency on people-based carers. I also think having an individual who's looking after an older person who may be isolated is much more likely to form a relationship and be able to support in terms of companionship over time than a robot. That being said, there will be specific areas where I think robotics can be helpful, such as moving individuals in their home, or even exoskeletons that support them in achieving that. So it will be a blended approach between greater robotics, but also expanding the care workforce in the UK and internationally. And of course, in COVID-19, we've seen large numbers of people unfortunately becoming unemployed or furloughed from retail, hospitality, airlines, and other sectors. And there is the possibility to take people who've lost roles and retrain them into social care to help close this gap as the population ages and the demand for care services increases.
That's wonderful to hear. And so following up.
To get into the Zoom chat, so you're going to have to tell me what.
So what can we do to implement digital care in a more smoother transition phase? Does anyone want to jump into this question? Ben, are you still there? So what's the biggest integration issue that you faced? Oh, perfect. Oh.
Challenge that we've experienced.
I think.
Sorry,
the question was, what's the biggest integration challenge that you face whilst integrating your startup into the social care system?
Oh, okay, thank you. I think because we are a regulated home care provider, we've actually slotted in the system quite easily, and we've tried to build technology with our stakeholders. So we've taken on board the challenges, the pain points that carers are experiencing on a daily basis, that people receiving care are experiencing, their family members, and even stakeholders such as local authorities and NHS CCGs. And by incorporating their user needs in our product development, we built technology that they want to use, that is very intuitive and easy to use as well. And that has meant the adoption phase has actually been quite straightforward. I think initially in our startup, when we were trying to achieve scale, there were growing pains, and it was difficult to get people used to understand how our technology works. But as we've taken on board people's views more and more, and we've actually addressed some of the issues that carers are experiencing on a daily basis, the adoption has become much more natural and organic.
Yes, and I do agree. So Daniel, do you want to jump in onto this question? Exactly what are the limitations in integrating this digital social care system into the NHS?
Can you hear me?
Yes, I can.
Hi.
Wonderful.
Hiya. Sorry about that. So I want to deal with that, Pedro, but I also want to come back to a question you posed earlier about whether technology and digital transformation can actually help us cope with the increasing aging population. And one of the things I want to bring out in this, and it links with the digital integration, is to say what the Rubicon has to be crossed of people taking their own self-care into account, because these digital tools now give us and the people we work with the ability to take greater care of themselves. So we've become used to the NHS looking after us. We've been used to reverting to care organisations. I think the great movement is the personalisation of digital care, and that will actually help some of the process. And that linked into, if we link in all this link, we talk about health and social care. It's not just health and social care. It's whether we link health and social care with housing, with population health, and with communities. Because if we're using digital social care to bring communities, what we have seen in the COVID situation is that actually community has been reborn in some way, because people are accessing, they're helping each other. And that is the great, digital technology as the great enabler will actually help us work to deal with the demographic issues that we have, the growing need, and it will also be the source for greater community. And that will then feed in to how the technology will follow the person, which will then lead to be a natural lead into greater integration between health, between care, population health, housing, and community, binding it all together. That's where the power is.
So there was one point you brought up, is about having the patient being at the center, but also the patient being in charge of their healthcare as well. And so seeing that, can we, in the social care system, it becoming digital, will patients be able to look after themselves? And so how would they know when they will need such helping hands?
First of all, Pedro, one thing, I never talk about patients. We talk about people.
Yeah.
People, because that's the paradigm shift, because we're all in this on a spectrum of health and care through our whole lives, be it a mental situation. So actually, I think there is greater purpose for us in actually taking control. And I think when we talk about robots, when we talk about exoskeletons, when we talk about, for example, digital tools helping people with autism try and recognize emotions, it's actually enabling the person to take control. So that now when you enter a health or care situation, you're actually plugged into a new system. If that system were with you, if there was that sort of system in community, you could take it with you and be plugged in, so the ecosystem is built around the person. Now, there's issues there in privacy and about how we deal with technology, but the real future is for us not to plug into systems, but to be part of the system as a community.
That's a great point. And Hassan, do you have anything else to add on to it?
I obviously agree with what Daniel's saying, but I'd like to take a different tack here. I think that healthcare and social care are both disconnected and reactive. So even if we tried to center ourselves on citizens, on people who are using services or not, we would still not be talking to each other within our systems. We're still not sharing information in an appropriate fashion that means that we can respond in the right way. So when we talk about AI, for example, AI is only as good as what we're feeding it with. So there's lots of issues in that system that needs to be put together again. And of course, we need to rebuild it around what you call the inversion of healthcare. It's what Eric Topol meant when he said, the patient will see you now, rather than it being the other way around, right? Passive, waiting for a hierarchical relationship with the doctor. If we can make that inversion work for us, where we're saying it fits around the service user, which is a citizen, a person, as Daniel correctly says, then we can build the system for them. But right now, do you go to, for example, an optometrist? Now, that's primary care to me. Optometry is primary care. But when you see that person in primary care, do you consider them to be part of a connected system? It isn't, unfortunately. You could go to Boots, and if you're lucky, the pharmacist might check your summary care record. There is a connection that's starting. But how does that go all the way down? I remember we did a project years ago, analysis on surgical site infections. So a surgeon would see you, cut you open, close you up, leave, and wouldn't know, there would be no information going back to the surgical team that you've come back with surgical site infection. The district nurse would know, but not necessarily that hospital, let alone that surgical team. Everything is very disconnected. So I think we have to connect everything together. And a big part of digital is enabling the citizen, but another big part of it is connecting those caregivers.
Whatever the newest one, I just updated it today.
Yeah, it must be 10.15.
Cool.
Question comes back to, actually links straight onto the whole data approach. Exactly how can we make sure that data is streamed into between different services? And so how should we as a public healthcare system tackle this, making sure that our hospitals, GPs, pharmacists, and also care at home are interlinked and data shared, while also not breaking any confidentiality clauses? What can we do about that? So how should we deal with it?
There is only one answer, and the common denominator in all interactions is the patient or the service user. Therefore, the data follows the service user, the citizen. They need to own the data. They need to have something like a passport and move through the system. And everything that we have should be a person-centered record. The Royal College of Physicians used to have an informatics department. And that informatics department did a report on how you can have a patient-centered record. So you wouldn't have somebody working, for example, in diabetes, only seeing that patient for diabetes and then that's it. It sits there. Then there's a Crohn's disease bit. So inflammatory bowel disease guys, they're looking at that bit. They don't talk to each other and the record never shared. It sits in separate departments. What if it stayed with the patient with a person-centered record? And that's what we're looking for.
I mean, I completely agree. I mean, there needs to be more to tackle this. And so should we not be innovating in this sort of sector instead of investing into more digital healthcare companies? Should we not be investing in integrating the data through a streamlined process? Isabel, what about you? Do you have any comments about the integration of data between your own startup and getting information from other sectors of the healthcare?
I think that is still incredibly complex, and because there's so many issues around protecting obviously patient data, and also often a lot of hospitals don't want any data to go out of their hospital as well, and I think that is I mean, when we look at hospitals that we work with in the US, for example, but any hospital. They have different levels of I guess gradation of sharing their or allowing access to anonymized even versions of their data, and I think until you get to a point where there's a kind of a really good understanding of what the data is that is actually being collected within the hospital, what they can allow in an anonymous way, for example, to share, what they can allow to interact with other systems, is something that is still in its infancy. I would say it is very important. The most important thing is to protect patient data and to not do any breaches there. But I think that there is great potential in having all the systems coming together, because obviously in our case, in neurorehabilitation, there's so many different stakeholders and clinicians and therapists involved in the whole patient pathway that they go through, from the time that, for example, had a stroke until the time that they are discharged, until the time that they then get into a community setting and then in a home, and all the all the kind of different types of therapies and I guess clinical aspects that come with it. They often don't have all the data shared with each other, and obviously this limits, for example, a clinician to make a full informed decision about changing drugs, for example, for this particular patient, or and then I'm in particular thinking about the neurodegenerative diseases that we work with as well, where neurologists often, I guess, struggle to to have enough data to make fully informed decisions about changing drug treatments, for example, for patients, as the patients themselves, they struggle with so many other issues, and the neurologists don't see their patients every day. They only see them once every 6 months potentially, when they come in for a checkup. So I think there's a lot of information that gets lost because of the lack of data tracking, but then also the not data sharing. But to do that in a good way, I think we're still far off of what could be an ideal scenario of data exchanging between different services. But it could be a great potential for improving patient outcomes and I guess the overall system working within health and social care in general. So yeah.
Thank you so much. I mean, I completely agree. I mean, the dream is to have your GP sitting at home, reviewing that patient record and being like, what should I do to the patient whilst they're at that care home or whilst they're at home? And what should we do? Should we get a nurse to go and visit her and make sure she's going back to, does she need any carers to come and visit her more frequently based on the data? I mean, that would be the dream.
Yeah. And I mean, just to give another example is that like some neurologists that we've worked with, and then I'm more thinking of when care is funded by, like in the US, most care is private care, obviously, and a lot of claims or a lot of, for example, follow-up treatments for changing drugs or requests for certain treatments by neurologists for patients that really need it are scrutinized because they don't have enough data to support the case that they're making that this patient actually needs access to this treatment because it will make the patient a lot better down the line. But because they lack data around their progress, for example, because they haven't seen them, and the patient, they are fatigued, they have mental health issues as well. They're not motivated to keep a diary or to really collect data in a really quantitative manner. So in the end, it's both. It's the therapist that is, or the clinician that is suffering, but particularly in the end, it's the patient and the people that are suffering most from it. So, yeah.
Yeah, and Daniel, do you have anything to add to this, coming from a Care UK approach? And you're on mute.
Thank you. I think there's three things to say here, in that we are actually seeing leadership now within the NHS, within an NHSX, really having pivoted to actually say one of its major raison d'etre is actually the joining up and the integration of health and care around the person. So we're seeing the whole agenda and they're putting resources behind it, which is really, really encouraging. And what we're also seeing is we're seeing providers of software solutions actually getting together with other providers, so providing their own ecosystem. And that's the way it'll go, that there'll be these software providers coming together to actually say we can work together and presenting this as a package. And the third reason is because the health system is now engaging with care providers. I work for something called Digital Social Care. So check digitalsocialcare.co.uk, because we're really getting social care providers at the table and not just being invited to the table later, but being part of the strategic answer. And that's where I think the hope is now. I remember hearing John Rouse, who many of you may remember, speak a long time ago, and he said there's the end of the world and there's 2 cockroaches still remaining, and they're still discussing the integration of health and social care. Now, I hope we get past that, because now we have the real opportunity, because we're empowering people and organisations that know people to actually come and work with the NHS. So that's real hope for the future.
I mean, I completely agree. I mean, something you discussed that was really interesting. I think Ben wants to add something to this. Ben, go for it.
Yeah, definite agreement with, I think, a number of the comments that have been made, in particular those around having a seamless form of data that follows individuals from place to place and that allows not just themselves to be more empowered around their care experience, but in turn the people who are looking after them or attending to them to have information at their fingertips, which allows them to provide a better service, but also one that's much more coordinated. I think one of the challenges we have across health and care is the disconnect the disjointed nature of services means that they can be inefficient, costly, and not centered on people's outcomes, or to the extent that they could be otherwise. And using data, by joining it up, creating greater interoperability between different providers across health and care, I think is a really powerful opportunity for us to transform and improve the services that individuals receive.
Thank you so much. And so I think we just had Hassan, I think that was his computer in the background being like, I want to speak. So Hassan, do you want to just jump back in, because you had that noise just telling us, yes, I want to speak.
Very sorry there, Ben. I was just going to say that people like Ben are the future, right? They're marrying the ability for a person to connect to another person with the fact that with digital, we can all be more connected. And really, that's the future, right? Isabel, what she's doing in Rehab using virtual reality, augmented reality is fantastic, right? And it really connects people to new experiences and helps them get over their problems. That's the future. But I think in order for us to really grasp the future, we have to be very, very brave, very bold, and radical. And that means taking on the vision. I mentioned the Royal College of Physicians Health Informatics Unit. The report was written by Professor John Williams, who was very unusual because he was a professor of health informatics and a consultant gastroenterologist. And he firmly, passionately believed in this one idea, that if you don't have a patient-centered record, the rest of it falls apart. You can have all the standards you like, and we've got lots of standards. You can ask all of your suppliers to get involved. You can form a unit like SpaceX, right, which is what NHSX is really based on. And you can say, yeah, we're going to do some great things, but it centers on one core thing. And if it isn't on that thing, it falls apart. And that is a patient-centered record. And that means you're going to have to convince Epic and Cerner and Allscripts and all the other electronic health record providers to say, yes, we'll follow it. You'll have to get TPP and EMIS on board. And that's one of the problems. That's one of the barriers. You have to throw away a lot of other things and start fresh with a new patient-centered record. And there's a lot of resistance to that idea because commercially it's going to be a problem. And that's why you have to be very brave and very bold and say, no, we need this. And if we don't have it, I'm telling you, honestly, we're going to struggle to see the kind of integration we really need around the data, around the citizen, and it's not going to happen.
I mean, that's a really interesting point you just brought up, getting a new patient record system. And so is it a must to get this, or is there not a way that we can transition the current record systems and put them into a transition process? And there's also the question of confidentiality. Whilst you're transitioning from a new record system to from an old one to a new one, aren't people going to be questioning what's happening?
There'll be no challenge about confidentiality because we're asking, just say company A that has its records in one form to map it to another form, right? So we're not asking them to send information anywhere else. We want you to have this mapping. Then we tell everyone to have this mapping, and then we tell them to talk to this system. And essentially, it's the same as you going abroad and you've got a plug, an adapter, and you need an adapter because every other power point, every other power socket is not going to be the same. You need an adapter. I'm saying forget all those adapters. We just need to stick to 3 pins, or we need to drive on the left-hand side, or whatever it is that you decide, right? If you're going to be on the escalator, stand on the right. It's just a way to make everyone fit together. And if you don't, citizens will suffer because we'll always be sitting waiting for the data holders to hold the same data for us to make decisions on. And the future that is promised by the work of people like Isabel and Ben will never really get the full potential.
Yes, and Isabel, do you want to just jump in right here?
Yeah, I mean, I think I'm repeating what I said before. Implementation will be key for digital health tools to really live to their full potential and reach as many people as possible and make use of integrated data from different aspects. But I think having an integrated system that is implemented in a way that doesn't put an extra burden on the healthcare system that already is dealing with so much strain and burden that they, and I think that will be a struggle. And I mean, and that is not only in the UK, that's in the rest of Europe, in the UK, in Canada, where we work. Everybody has very similar issues where they want to help a patient. They're looking for tools. And in our case, they're really looking for tools to help their patients improve better, have better outcomes. But often they don't have the access to it. Then implementation is hard, or is kind of, it's not easy to do it within the hospital setting, or it's really a struggle. So that obviously limits adoption, and hence this then there's no take up and so on as well. So they can't help their patients. But I think, like coming back to what Hassan as well said, and Daniel, I think having a lot of companies kind of really, I think collaboration is key in all of this. And it's working with the stakeholders, with people that are working within hospital systems, people working within tech companies that already today have really kind of, I guess, a monopoly or almost a monopoly of the patient electronic systems, the electronic health record systems, and see how we can actually take that to the next level to just implement other tools within digital health that could actually leverage the healthcare for everyone essentially down the line, and not at the same time increase price as well, because I think that is often, I mean, this is really important to make sure that it remains accessible to everyone, and digital health has an opportunity to democratize healthcare. But obviously, if the implementation becomes a barrier, then obviously that often puts a strain on the price, and prices are being pushed up. And that obviously is not the point as well, because it's the point is to improve the healthcare for everyone. And that's why I'm very excited about reimbursement plans, systems that are being set up in different countries and so on, which I think will be very important to actually push it forward as well, and for hospitals to take it up as well, because otherwise, yeah. So it is a lot of different aspects that need to come together to have really digital health take up its full potential, and it is there. But yeah, there's some things that really need to be tied together to make it fly, I guess. Yeah.
And I see, Daniel, you have some concerns about what Isabel just said, looking at your face.
Okay.
And coming into what Hassan was saying, because what we're seeing here is the need for central control, but the potential for disempowering the person. So there's a fine balance to be made between actually preventing tools that the individual, that the person can use, but also having the center guiding the system. So, and I'm not sure where to go on this one myself yet, whether we should be encouraging. One of the greatest things about the innovation, the tech innovation sector, is it encourages new entrants. So once we start centralizing and getting people on frameworks, you're potentially minimizing the innovation potential. So I think the balance has to be there of a central system, a central ecosystem being set up into which new innovation can fit, but less central control. And for me, that's one of the, in what Hassan was talking about there, one of the balances that we have to get right. And we're at this almost a storming phase where all the new technology is being found, but it's not yet fitting together. So I think there's a balance here for us to get. And I'm not sure how to get there. I think NHSX is starting to take a lead on this, and I find that very encouraging. But I think the balance might get lost between the individual and the central control. And I think we should all be wary of that.
So let's just pan into Hassan right now, because Hassan, you have something extra to say.
So Daniel's absolutely right that there has to be a balance, right? We can't disempower people, and too much central control has been a disaster for us in digital health, in IT, and all the strategies that we've had. We suffered MP Fit as an example. What I'm arguing is we need to come to an agreement philosophically on what we are following. Are we following activity? In which case we will pay for activity, we will record activity, but when no activity happens, there's no money. And therefore prevention is hard for you to incentivize. And unfortunately, that was one of the approaches that we've taken with payment by results. on the healthcare side, when we are looking at a record that is centered on a citizen, and all of their activities are centered on them, then everything changes. So I'm saying there should be a philosophical change. There needs to be a minimum data set. So the Royal College of Physicians wrote about minimum data requirements, and NHS Digital and other bodies agreed that we do need minimum data sets within that. So for example, a discharge summary or an outpatient record, there needs to be some minimum record. Then all of the innovators can add beyond that. They can go further. But once you've got us all on the same page, we can continue. And NHSX's role is really to find that future, center us all on it, and find the way for industry to be involved appropriately. My argument, though, is we need to be bold and say it's got to be a patient-centered record, regardless of the amount of lobbying we're going to get from companies that are going to say, well, it's too hard. And I can say that for a surety, because when we had NHS Digital insist on SNOMED CT, so the nomenclature, the clinical terminology to be inserted for primary care, they did it, but it was hard. And clearly that took a lot of pressure, a lot of cajoling, and it's going to be even worse with this.
So let's talk about future. So let's say X startup is integrated into the social care system. And so we go down the line and there needs to be further development or improvements on that startup, that digital healthcare system. Something that's been historically known is that the NHS tends to be old-fashioned and tends to not deal well with improvements on a current system. And so, for example, we still use fax machines. Some GP centers are still based on written paper notes. So how can we make sure that the improvements on these digital healthcare systems are embedded and can be improved at any time without compromising data? So this seems like a hard question.
I'm happy to come back in on that one. The NHS has got patchy adoption of what is good. So you've got some outstanding examples and you've got some pretty bad ones. And it's not a single NHS. For example, I remember speaking to some American colleagues who thought the N was numerous because after experiencing the system, they just realized this is many. It's like Napoleon trying to take Russia. It's a long battle, right? I know that the NHS with the right incentives will do the right thing. And we've got to reach down to the benefit for clinical teams and non-clinical teams to take that change. There was no incentive for a long time for a lot of these changes, but people move. Transformation happens because you can see what the benefit is for you. So we've got to make it easy for people to see the benefit and drive the change when people are passionate, not imposing the change. So axing the facts wasn't difficult. But I tell you, honestly, at the time, people got used to it. They weren't bothered about whether there was a fax machine or not. It was annoying that you had to call someone to say, stand by the fax machine, just in case the information goes missing in between the transmission for GDPR purposes. Those things were a bit annoying, but it wasn't annoying enough for you to move. So let's find a way that will get caregivers, people who are clinical and non-clinical, to say, yeah, I want this change. And I think you will see mass adoption of the right tech.
I was saying, can I come in there?
Yeah, go for it.
I think Hassan's right. It's about empowerment of the person. People will make things happen if they're empowered with the tools. So I think this, again, it comes down to empowering the person and that they need to have the infrastructure to fit into. And this is where NHS Digital with SNOMED set a base on which information should be collected and data shared and analysed. And I think there needs to be another step up now on creating that central platform for people to participate in. So I actually think there's more optimism now than there has been for a long time in digital care recording, digital following the person, actually making a difference and bringing services together, making sure that comorbidities are taken into account. There's a campaign which a guy in NHS Digital, a guy called Keith Strand's been leading, which is the about me part of a care record, so that a person's individual characteristics are taken into account in their whole healthcare. So if someone doesn't like loud noise, it's known, And that sort of thing will actually lead to an integrated health and care system. So I think there's greater optimism now than there has been for a long time.
And so coming to Ben for a second, how did you find the innovation sector in the NHS when you first started out? Like, what sort of support system did you wish you had?
So I think the NHS is great at having pockets of practice, excellence and innovation, and people who are passionate about adopting innovation. I think where it experiences challenge is widespread scale, which is somewhat ironic given it's the National Health Service. But of course, if we look with a more detailed lens, there are hundreds upon thousands of organizations within the NHS, from many, many GP practices to hospitals to support organizations and so on. And so achieving scale in a complex system such as the health service takes time. And it also takes time for a startup and an innovator to determine where their product fits in, where it can create the most value, where different stakeholders see it as helping them in their day-to-day. And it took us definitely 1 to 2 years to really figure out what the right model was for achieving traction and growth and what was most attractive to potential partners. But then once we cracked that, the company was able to expand very, very quickly. So it is a complex framework and complex terrain to navigate. But I think once you get there, rapid growth and scale is possible.
No, I completely agree. I mean, Isabel, do you relate to your own experiences starting your own startup? What did you face what barriers did you face?
I mean, I guess from the clinician perspective, for example, they realize the need, they know kind of what tools they would need to help patients get better. So the appetite, as Ben said as well, from them is vast, and they are very open, and they were always very open in collaborating and opening their doors and their departments for us and getting in their patients and everything as well. But I think it's obviously it's getting to that scale within the NHS similarly to Ben is hard, and also because of the systems, how it works within one hospital, and then you have the trust, and then obviously you have all the so the bureaucratic barriers, I guess, are really kind of, I guess, limiting is maybe not the right word to say, but it's hard for adoption. It is to really get it to a stage that you can really show and deliver it to all patients across the NHS. And then also having to obviously prove your health economic value aside from the patient outcome values. I think that is something really critical for the National Health Service in terms of obviously there's restrained budgets that obviously you would need to align with what can we bring for you aside from the patient outcome improvements on a health economic level as well, and where it could be potentially cost savings that play a role. So I would say it is still an ongoing I guess journey with the NHS and adoption, and but from the clinicians and the therapists that we've worked with so far, I can only say it was amazing to work with the people and the drive that they have, and the willingness to work with innovators. But yeah, it's getting to that next stage, I guess, to then really get to a scale.
But she did come to a really interesting point right now. And so, Isabel, just because you came from a non-clinical background, if I'm correct, how did you find integrating yourself into the system, like learning about it? So what did you have to learn about the social care system? Like, what was the biggest surprise about it?
I mean, so many things. Working within healthcare is very complex. I mean, it is complex in terms of just one from the interaction with the clinicians and patients. It's something that you really need to approach in the best possible way. And we've always approached it in a very co-development, co-design way, where the clinical staff was always involved from day one that we've done anything. I was also a patient myself, so that's why I started the company in the first place, is that I went through rehab myself, so I know it as a patient, to go through a very long rehab period myself. And but then, yeah, all the systems about adoption and really getting it implemented in a clinical setting, what goes into that is still a learning curve today. Every day I still learn new things, especially we work in different regions as well, across the world. And I think that it is incredibly fascinating to work in. But yeah, that definitely, I've always approached it from a very collaborative standpoint with the clinical staff and the therapists and the patients as well, to ensure that we develop the best possible solution for them, with patient outcomes improvement at the heart of everything. So yeah.
Yeah, and so discussing a bit more, so if you had to be able to start over all again, how could the NHS enable you to get that headspace for innovation? What could they have done differently to ensure that your social care startup is going to be more effective and reaches out to more people? What sort of tools were you looking for from them?
I guess one, openness, not from the clinicians, so not from the clinical side, but openness or understanding in the whole system. And I think it's a very closed system still today. I think it's a very closed system on how it works and how to approach. Even people within the hospital don't really know even who to approach to get it to a next stage, so I think it is. I guess educating or opening how they work in a more transparent way. I think that would be incredibly valuable for any innovator within the healthcare space, because in the end, we want to improve patient lives just as the NHS wants to do that, or any other big healthcare system. But obviously, collaboration without collaboration and full understanding how both parties work, adoption will always be very difficult. And I think, having a better view on what the different steps are and kind of who the different players are within the system would have been incredibly valuable. Yeah. So, but I mean, we're very happy with organizations like Digital Health of London, for example, MedCity. They've been always very helpful in getting a better understanding around that as well. But yeah, I think that is what I would say.
And so coming to Daniel, we talk a lot about NHSX and the whole form of leadership behind the NHS to promote innovation. How can we ensure that the NHS enable the headspace for innovation for the future?
I think it's engaging some of the principles that Isabel was talking about there, about engaging people. I mean, I'm big in favour of hackathons, about getting people together. So if you get tech experts together with the people that actually require the solutions or discuss their problems, so it's actually greater co-production, which again Isabel mentioned very much there, and Ceracare does Ben does that with his organisation, about bringing the users and saying what they want and translating it to people. So that will lead to greater transparency that Isabel was looking for there. So I think the way to unlock it is actually focus people on meaningful lives for individuals, for people, and then bring them into the innovation process, because then we can start to see that NHSX, as Hassan said, is starting to prepare that bedrock. And if everyone can be involved in building on that bedrock, that's the way to innovation. And the philosophical change that Hassan talked about as well is needed in the whole. So it almost needs a public information campaign to say, we're all in this together. We innovate for health. We take responsibility for greater health. We're frank about the resources that we have, and we involve people to help innovate and build on innovations that are already there.
I mean, Hassan, do you want to jump into that to add to chant your little point?
It's really difficult to talk about innovation in the NHS when Ben's on the same call, because but I'll say this very quickly. Innovation happens when you can get away from the corporate culture that is not about innovation. So NHS organizations have to deliver care. Social care organizations are also delivering their own form of support. You've got to get out of those environments to innovate. You learn from those experiences, but you don't innovate in them. And the classic example of having a bridge to an island, right? So your island is where you have your rebels, they do their innovation. And Pedro, we've discussed this before on HLA Live. That's what's needed. And the NHS and social care won't have innovation happening in it in a purposeful way unless they provide people the chance to just go away. And that's why so much of the innovation happens from frontline clinicians and those who've worked on the front line, who've moved out of the system for a second to think, well, I've got an idea, I'm going to do it separately. Therefore, the real question's got to be, when someone does have some great innovation, how can we help them shape it? How can we direct it? And how can we accelerate it? Ben is obviously behind the foundation of the NHS Innovation Accelerator, which finds the right innovation and helps it move. And that's really what we're looking for. If you have a great idea, you'll get to ask the right questions, you'll be given a chance to see how to navigate the system, and then you'll be accelerated towards scale. And Ben did mention scale earlier. The hard part with innovation isn't finding it. We've got great innovation here, but how to make it fit everywhere, that's the tough part. And the headspace that you need isn't really about getting away from the system. You can do that. It's about finding someone who's going to give you some tough love and tell you your idea stinks, or you haven't identified your customer properly, or there's no money in this because you're targeting someone who has no budget. When you hear that early on, you can work it out, but you need that question to be answered early.
So coming to you, Ben, so you sit on the NHS Accelerator right now. What sort of advice do you give to people? Because you are, I'm presuming that you've been seen as some kind of mentor to people. So what kind of advice do you tell people when they want to innovate in the NHS?
Mm-hmm. Firstly, I'd say, I fully agree with Hassan, and I like his imagery in this panel. We've gone from aeroplanes to beaches and bridges and so on. So that's great. I think it helps people to really understand kind of the complexity of the health service in a more simple way. When it comes to advice, I think, again, linking to what Hassan said, first, people need to be empowered. I think there are 1.3 million staff in the NHS. There are around 1.5 million staff in the care sector. If just 1 in 100 individuals has a new idea that's going to make an impact, that's tens of thousands of concepts that could be incubated and supported in a massive health and care ecosystem. So empowering those individuals to really be able to run with those ideas, but also sometimes giving them some tough love, because not every idea is a great one, and not every idea is one that's going to achieve traction and make a real impact in the health and care sector. And I think a couple of areas that people sometimes find difficult is, one, they don't necessarily focus on what I would say is the right demographics. Many health and social care apps focus on the young or the worried well, rather than the people who have multiple health conditions or particularly vulnerable or have significant disabilities. And that, of course, can sometimes widen inequalities rather than closing them, because if we're empowering those who are well with technology, but leaving behind those who have multiple health conditions, it will actually cause them to separate further rather than trying to standardize and make care more consistent across the country. I think another item is that focus on a real problem. It's very easy to come up with a shiny piece of technology or innovation which sounds good on paper. And there are over 300,000 apps on the App Store, and that's a testament to that. But only a small number of them really receive traction and scale. And of course, that's because not everyone focuses on a real problem that frontline staff necessarily experience or that people receiving care experience. And so factoring that in is really important. And then, of course, thinking about regulatory challenges. Healthcare is rightly regulated, and so is social care. We're dealing with people's lives, not just sending books or pieces of food to them. And as a result, I think some startups fall down when they aren't considering regulatory challenges early enough in their journey. They build a great product, they try and roll it out, but then they get a couple of knocks on the door from the CQC or the MHRA. Factoring that earlier in will allow you to build a more sustainable startup long term.
And so coming on to that, how can we ensure that we have the right conversations with those in the health sector and the policymakers? So I'm going to put this question towards you, Hassan, since I believe you're the only one on the panel with a politics degree, actually. So you know quite a lot about policy making, etc. So what conversations do we need to have with the health sector and policymakers?
So the first thing I'd like to say is that you ignore them, right? Because to follow Ben's advice correctly, you have to focus on the problem, identify the problem, identify where the money is, and get yourself a champion, get yourself a pilot, get yourself some evidence. It's only at that stage that you can have conversations. But if you haven't done all of those, they're not going to listen to you. So your first port of call isn't to do with healthcare leaders or policymakers. It's to make sure you've got a viable product. Pivot as many times as you need to get to that point. But when you've got it, when you know what you have, when people have told you this works and I'm going to buy it, then you're going to go to those leaders and say, this solves a problem here, and then here, and then here. For example, Dorset, Newcastle, Liverpool, we've got 3 projects. They've all done well. Now I want to go big. And that's the conversation that you need to have very openly. Now, lots of innovators stop at that point because they don't know how to get to the right conversation, to the right people to have the right conversation. So that's why a couple of initiatives have come up, which I should mention. One is Future NHS, which is a collaboration which I think has 100,000 people on there now, all working in health and social care, currently run out of NHS England, done a fantastic job. Their data analytics for COVID-19 has 8,000 analysts on there already. And they're all collaborating and looking for that innovation. They're the ones that need to see what you've got. And when they believe in what your product is, you're going to get traction with healthcare leaders and policymakers. But you've got to get that started. And another one is called Tech for CV19, which I'm very proud to be part of. And Tech for CV19 is 1,000 people that came together during the height of the COVID crisis to say that they were innovators and they wanted to collaborate and get the right conversations happening. When you get in those environments, you will see innovation happening. But don't focus on the policymaker, focus on the problem, and then go to get your pilot, get your champion, get your evidence.
So, Isabel, do you have anything to add yourself onto this?
A final thing that I would add to what Ben and Hassan have said already now is, I think a thing that policymakers could be involved in from the start and already now is the clear path to reimbursement for digital health products, digital therapies. Because now it's still, some countries are starting it and they have kind of some approaches to how to best reimburse products, but it's still a very early stage approach. And I think having more clarity on that front and also seeing the urgency of implementing it is very much linked to having reimbursed solutions on the market as well, because having reimbursed solutions will actually give people access to the solution as well that they need. And now I'm talking about, obviously different countries in different areas of the world have different approaches to this, but I think this will really help with, one, the regulatory approval that is needed within the digital health solutions in particular is so crucial to then get to the next stage, to then get reimbursement in place. If you look at the Digital Healthcare Act in Germany, for example, it's quite impressive to see what really the aim will be there to achieve in the end. And I think that is something that could be achieved across the world to really, when you have a regulated, validated, clinically validated solution, that actually then gets reimbursed after ticking certain boxes again. But then this will ensure that it will get into the hands of people. And I think that is really crucial for regulators, policymakers to think about today, not when products go live. So, yeah.
I think that's all we have time today. So tonight we had a lot of interesting conversations about the different aspects of digital social care as we went along, from being people-led to integrating this, the services along a more streamlined process and the need for that. and also to finally discuss how should we innovate in this sector. So I'm going to pass on the spotlight to Johan now as he comes to close the session. And I'm presuming Johan.
Hi, so thank you, Pedra, for a absolutely fascinating and extremely well-chaired session. And one of the things that we have definitely seen is the massive improvements that social care innovation has had. And thanks to many of the kind of innovators that we've seen tonight, actually, the startups and the technology that we've seen innovating in what has been a heavily neglected part of the health and social care sector is starting to really see the benefits of innovation and technology. And so I think hearing from today's speakers and hearing about the incredible work that many people are doing has been really incredibly reassuring, and also hopefully has been motivational for many of the people that we've got out there in the HLA community that are thinking about where they can direct their endeavors and their work for the future. So thank you to everyone who spoke tonight. Thank you to Pedra for hosting tonight. The HLA is all about the incredible people in the community, and we are incredibly lucky to have scholars that want to make a significant impact on healthcare systems across the globe. They use the HLA as a platform to bring together their incredible ideas and innovations to fruition. If you are interested in the work of the HLA, do make sure you catch a future HLA episode. Join us at a HLA event, apply for one of our programs, or apply to become a HLA scholar. Thank you for joining us. I'm Johan Malvina, and it's a good night from all of us.